We are live.
Okay.
Great.
Yeah, see. I think many were waiting.
Yes, sir. Yes, sir.
Hi, Amit.
Good evening, Dr. Srinivas. How are you?
Fine, fine. ओपी खत्म हो गया क्या? अभी भी चल रहा है?
हाँ, नहीं खत्म कर दिया मैंने।
शुरू कर ले यार, शुरू कर दिया लगता है।
12 बजे तक चलता है।
या उसके बाद राउंड चलता है 12 से 2
हाँ।
बजे। हम्म।
Sharanya, are you here? By name of NNF faculty, I think.
No.
No? Okay.
ये शरण्या कौन चेन्नई में वो
Nine, seven, six.
नहीं. Okay. She's in the attendant group. I think we have to make her as the host, as a panelist. Sharanya
Road?
Potireddy.
I will do, sir.
Okay, Sharanya Potireddy. There are two Sharanyas. Sharanya Potireddy.
Okay.
Okay.
Okay, I think she is joined as Sharanya now. Okay, ठीक है. Okay, she joined. Yes.
Okay.
Can you make full screen, Sharanya? Sharanya, can you make full screen? No, down. Or from, yeah. ठीक है, go down at that arrow, no? Yes. No, next to that. Yeah. And that arrow.
The orange arrow.
Yeah, orange arrow. Your current slide is also, yeah, this. ठीक.
Yeah, good evening, everybody. Welcome all to session 9 of the monthly NNF Journal Club. Today's article, which we are going to discuss, is a multicentric randomized control trial on nasal non-invasive high-frequency oscillatory ventilation versus nasal CPAP. And we are fortunate again to have experts with us. It's mentored by Dr. Srinivas Murthy sir from Ankura Hospital. And he'll introduce the student and the presenter to us. We have external faculty, Dr. Mangla Bharti sir today, and we look forward to an exciting session again. Murthy sir, welcome sir, and please introduce the student and then she can present, sir. Start presenting.
Thank you. So Sharanya, can you go to the first slide? You're not still full screen. Please make it full screen first. Is it difficult?
Yes, sir. I'm unable to do it a full screen, sir.
So stop sharing first.
Sir.
Stop sharing, no?
Yes, sir.
Yeah, try again now. Yeah, desktop only. Yes, share. share the desktop.
हाँ,
Now
yes,
it is okay. Yeah, ठीक है. Go back to the first slide, no, please.
yes, sir.
तो उसको मेल भी कर देना और सब भी कर देना.
Still not able to go.
Yeah, one of them.
Yeah, first slide. This is not.
Yes, sir.
Can you put on your video on, Sharanya?
Yes, sir. Good evening, sir.
Yeah. So good evening, everyone, and welcome all of you for this interesting journal club. And at the outset, I want to congratulate NNF for hosting this on a regular basis. And I also want to thank my mentor, Dr. Saurabh. Dr. Saurabh has just joined. So, sir, good evening, sir. So he is the brainchild behind these brain father behind this NNF Journal Club. And before today, we'll be presenting this journal, non-invasive high-frequency oscillatory ventilation for preterm for primary respiratory support in extremely preterm babies. This trial is a multi-centric randomized control trial, and the presenter is Dr. Sharanya Pothireddy. She is a fellow in neonatology, and she's from Fernandez Hospital. So over to you, Sharanya. And our experts for today, our clinical expert is Dr. Pratima. She is a senior neonatologist from Delhi. She is DM neonatology from AIMS Delhi. And Dr. Mangla Bharati is again DM neonatologist from PJ Chandigarh, and he is from ICH Chennai. And Dr. Saurabh is professor of neonatology at PJ Chandigarh. And we also have NNF president, Dr. Lalan Bharati, along with us. So we have 120 people in the webinar now. So over to you, Sharanya. Please go ahead.
Good evening to all the people present here. I thank for the opportunity for giving me to present this journal today. I'm Dr. Sharanya Pothireddy. I'm doing my fellowship in neonatology currently in Fernandez, Hyderabad. Today we are going to discuss about the non-invasive high-frequency oscillatory ventilation as a primary respiratory support in extremely preterm infants. It is a multi-center randomized controlled trial published in BMG in 2025. Why this comparison is important? The primary threat. Respiratory distress syndrome remains the leading cause of respiratory failure in extremely preterm infants, mainly less than 20 weeks of gestation age. The nasal CPAP is in the European consensus is the first line strategy, but extremely preterm infants suffer a 40% failure rate due to severe chest wall recoil and poor diaphragmatic strength. In one of the study published by Murke et al. Done in our institute shows that the CPAP failure rate is 15% in more than 28 weeks of gestation age. The intubation cascade, failure forces tracheal intubation and invasive mechanical ventilation directly correlating with ventilator-induced lung injury and bronchopulmonary dysplasia. So nowadays, the non-invasive support had become the main role to prevent the bronchopulmonary dysplasia as well as ventilator-induced lung injury. Mechanisms of action. What differs in HFOV, nasal HFOV versus nasal CPAP? In nasal CPAP, it provides continuous distending pressure to maintain drug recruitment. But in extremely preterm infants, due to infants' weak spontaneous breathing efforts as well as due to chest wall recoil and weak diaphragmatic strength, the failure of the CPAP rate is high as well as intubation rate is more. The NHFOV advantage in this aspect superimposes active high frequency oscillations onto continuous distending pressure. These high frequency oscillations can lead to CO2 elimination. The CO2 elimination is an active process in HFOV because the oscillations actively remove the carbon dioxide. Inspiration and expiration is active and expiration is passive in NCPAP mechanism, but in NHFOV the inspiration as well as expiration both are active process due to these oscillations. Due to high mean airway pressure provided by NHFOV, it maintains alveolar recruitment without requiring patient synchronization and actively clears carbon dioxide to turbulent flow, radial mixing, and pendulant effect. Now we are going to discuss about the study. The study design is multi-center randomized control trial. The study site is China, 20 tertiary care NICUs with combined 1000 beds with 1000 extreme preterm with admissions with RDS each year. And study population is 24 to 28 plus 6 days neonates. And study period is from December 2018 to December 2020. And study sample is 342. The study was published in BMJ in 6th October 2025. Record statement 342 extremely preterm neonates were enrolled. Intervention and comparison are NHFOV versus NCPAP. Outcome is invasive mechanical ventilation within 72 hours after birth, and time is 2 years, that is from August 2022 to August 2024. Inclusion criteria. Neonates of 24 to 28 plus 6 weeks are enrolled with a diagnosis of respiratory distress syndrome. Diagnosis of RDS is made by clinical criteria, that is tachypnea, grunting, and retractions. Pre-randomization support was given with nasal CPAP set at 6 cm of PEEP after delivery room stabilization of 6 to 8 cm H2O as per the local guidelines. And FiO2 criteria was 25% to maintain a target peripheral oxygen saturation of 89 to 94%. And the time of enrollment was less than 2 hours after birth, and informed parental consent was taken before the randomization. Exclusion criteria. Intubation for any reason at birth, major congenital malformations or non-complex congenital heart diseases, transfer out of the neonatal intensive care unit before randomization. Randomization. Simple randomization was done. Computer generated random number sequences were taken, which were securely posted on a dedicated password protected website, which was accessible for all the time. Randomization was centrally managed by website, ensuring allocation concealment. Stratification was done only according to the center. Twins were allocated to the same group. Masking. Masking of caregivers was not possible due to the obvious nature of the study, and masking of the patients were not applicable. Outcome data recorded by investigators who were in part of the NICU staff, and they reviewed the patient file with mask treatment strategies. Procedure. In the delivery room, stabilization was done for all the babies with 6 to 7 centimeters of centimeter PEEP and were transferred to the NICU with continuous NCPAP support. NCPAP at 6 centimeter H2O for a minimum of 30 minutes was given before randomization to establish uniform baseline respiratory support conditions for all the babies. Device for CPAP. Continuous flow devices were used, which is Mindray and Common NV8. A nasal CPAP group was started on a PEEP of 6 centimeter, which adjustments up to 10 centimeters according to oxygenation in the increments of 1 centimeter each. The FiO2 was started with 25%, with adjustments up to a maximum of 40% in increments of 5% to maintain a preductal saturation of 89 to 94%. And HFOV. The instrument used for HFOV was piston or membrane oscillator capable of active expiration. The instruments were Accutronic, SLE, and Leone. Mean airway pressure was started of 6 centimeters, same as the nasal CPAP, with the maximum of 6 to 10 centimeter with increments of 1 centimeter. And frequency was started with 10 Hz, which range was between 8 to 12 Hz. And inspirated time was 50%, which is I to E ratio of 1:1. Amplitude is of 15 centimeter, modifiable in 5 centimeter increments with a range of 15 to 30 centimeters. Interface. Here both nasal CPAP and nasal HFOV were administered using the same short binasal prongs. No masks were used in the study. Prong size was selected based on the diameter of the nares, ensuring the best fit, the largest prongs that fit the nares without causing blanching of the surrounding tissues. caffeine administration. Prophylactic caffeine treatment was administered within the first 24 hours after birth. Initial loading dose was 20 mg per kg and maintenance dose of 5 mg per kg. Surfactant treatment. If FiO2 crossed 30% and with PEEP of more than 6 centimeters, surfactant was given, which is Curosurf. Initial dose was given at 200 mg per kg by Lisa technique, and repeat dose was given as 100 mg per kg. Within intervals of 6 to 12 hours, maximum 4 doses of surfactant were permitted in the group. Adjunctive therapies. Antibiotics were started in all the newborns with RDS until sepsis is excluded. Fluid treatment is according to the unit protocol, which was started at 70 to 80 ml per kg, with subsequent adjustment individualized based on the fluid balance, weight changes, and serum electrolyte levels. And PDA, for PDA, 2D echo screening was performed in the first 3 days. HSPDA was treated with ibuprofen 10 mg per kg to 5 mg per kg doses at 24 hours interval orally, and surgical ligation was done if 2 courses of ibuprofen was given and there is still persisting HSPDA. Primary outcome. Primary outcome was respiratory support failure, which is defined as the need for invasive mechanical ventilation within 72 hours after birth. Need for mechanical ventilation. Severe respiratory acidosis, which is defined as PCO2 more than 60 mmHg and pH less than 7.2 for at least 1 hour. Hypoxia refractory to study intervention, which is defined as saturation less than 90% with FiO2 more than 40% for at least 1 hour after surfactant administration. Severe apnea, which is defined as recurrent apnea more than 3 episodes per hour, heart rate less than 100 minutes, or a single apnea episode requiring bag and mask ventilation, and urgent intubation as determined by the attending physician. Secondary outcomes. Secondary outcomes were the reasons for treatment failure, the need for invasive mechanical ventilation within 7 days after birth, surfactant treatment, hemodynamically significant PDA, IVH, necrotizing enterocolitis, retinopathy of prematurity, duration of supplemental oxygen, bronchopulmonary dysplasia as defined by NICHD 2019 criteria. Safety outcomes. Pneumothorax, death, thick secretions causing the airway obstruction, and grade 3 to 4 nasal injury were taken in the safety outcome measures. Sample size calculation. In the sample study, they had taken 30% risk of failure in NCPAP group was seen, with 15% absolute reduction in failure on HFOV group was taken, with a significance level of alpha of 0.05 and 90% of power. 170 newborns per group were required, leading to the total enrollment target of 340. In the study used by Zhu et al., based on which sample calculation was done, a total of 76 infants were enrolled. The need for invasive mechanical ventilation was significantly lower in the NHFOV group compared to the NCPAP group, which is 24% versus 56% with a significant p-value 0.01. Statistical analysis. Statistical analysis was done on intention to treat basis. Standard statistical tests for dichotomous and continuous variables were taken. Two-tailed p-value with less than 0.05 is considered significant. R software was used. No pre-planned subgroup analysis was done. Sensitivity analysis was done by adjusting CRIB2 score, PaO2 before enrollment, study site, and antenatal corticosteroid individually in all examined associations. 684 infants were assessed for eligibility, of which 324 were excluded, of which 276 did not had met the exclusion criteria, and 35 parents were refused to participate, and 13 got transferred before randomization. Consent was obtained for 360 babies, of which 18 of the consents were withdrawn, and 342 babies were randomized, 170 to NHFOV group and 172 to NCPAP group, and 170 were analyzed and 172 were analyzed in NCPAP group. Here are the baseline characteristics. The mean gestation age in both NHFOV and NCPAP group were comparable, which is 27 weeks, and mean birth weight was also 990 and 970. And chorioamnitis rate was 8.2% in NHFOV group, and NCPAP group it was 5.2%. And prenatal corticosteroid prophylaxis was taken in 70% in both the groups. Caesarean section delivery was done in 43% and 45% in both the groups. And here in CRIP2 score, the NHFOV and NCPAP group, the difference was significant, with higher CRIP2 scores in NHFOV group, and PaO2 before enrollment was also higher in NHFOV group compared to NCPAP group, which was significant with a p-value of 0.05. So sensitivity analysis were performed by taking into these two into the categories CRIP2 score and PaO2 before enrollment. Primary outcome, which is the treatment failure within 72 hours. In NHFOV group, the proportion of the treatment failure was 15.9% versus in NCPAP group, the treatment failure was 27.9%, which is with the absolute risk difference of minus 12 percentage points with a significant p-value 0.007. The number needed to be treated is 8, with a confidence interval of number needed to be treated is between 5 to 30. The refractory hypoxia is the primary driver of failure, significantly mitigated by active intervention in HFOV. In NHFOV, the proportion of babies with refractory hypoxia was 11.2% versus 18.6% in NHFOV group, with a risk difference of minus 7.4% with a significant p-value of 0.05%. And rest all the other parameters which are led to mechanical ventilation were not significant between both the groups. Severe apnea was 2.3% in NHFOV group and 5.2% in NCPAP group. Severe respiratory acidosis were 1.2% in NHFOV group versus 2.3% in NCPAP group. Urgent intubation was 1.2% in NHFOV group versus 1.7% in NCPAP group. When we come to the secondary outcomes, treatment failure within 7 days, the proportion of treatment failure within the 7 days was 21.2% in NHFOV group versus 33.7% in NCPAP group, with a risk difference of minus 12.5 percentage points with a p-value of 0.008, which is significant. And surfactant treatment requirement was 84% and 86% in the groups, which was not significant, and multiple doses were required, each 88% group of 8% of the proportion of the babies required multiple doses of surfactant. And bronchopulmonary dysplasia, total 38% and 44% in the respective groups, with the p-value is non-significant, and moderate to severe BPD also 8.8% in NHFOV group and 13.9% in NCPAP group. The p-value is non-significant. Duration of supplemental oxygen in each group, it is 35 to 37 days with a median difference of 0 with a p-value which is non-significant. And the secondary outcome, only significant was found between treatment failure within 7 days. Safety profile and serious events and morbidities. Theoretically, HFOV leads to more barotrauma, so more focus was given on the air leaks. But as we can see, 0.6% of the proportion of babies had air leak in HFOV group, and in NCPAP group, 2.3% of the babies has air leak, with a risk difference of minus 1.7%, but the p-value is non-significant in this case. And grade 3 to 4 nasal injury, it was seen in 2.9% in NHFOV group with NCPAP group of 5.2% with a risk difference of minus 2.3 with a non-significant p-value. And intracranial hemorrhage, which was also thought theoretically due to high mean airway pressures. It is thought that in NHFOV groups more prone to intracranial hemorrhage, but here we can see it in NHFOV group 8.8% of proportion of babies, and in NCPAP group 9.3% of babies had intracranial hemorrhage with risk difference of minus 0.5 with non-significant p-value. And death in the hospital 5.3% in NHFOV group and 7.0% in NCPAP group with a non-significant p-value, risk difference of 1.7. Secondary outcome. As we discussed, bronchopulmonary dysplasia is 38.2% versus 44.8% with a p-value of 0.022. Mortality is 5.3% versus 7.0% with a p-value of 0.52. And air leaks are 0.6% versus 2.3% with a p-value of 0.18. And surfactant treatment needed was seen in 84 versus 86% with non-significant p-value. And grade 3 to 4 nasal injury was 2.9% versus 5.2% with non-significant p-value. And thick secretions 7.1% versus 5.8%. Here thick secretions were defined as the secretions which were obstructing the airway. And grade 3 to 4 nasal injury, they did not mention which type of grading they were using, but the reference article which they had mentioned, grade 1 is erythema, grade 2 is erosions, and grade 3 is necrosis. And gas exchange parameters at 24 hours after enrollment. As we can see, PaCO2 was lower in NHFOV group, and median difference was -2 with a interquartile range of -3 to 0 with a significant p-value of 0.009. As we can see, mean airway pressure also is higher in NHFOV group, which is 8 within, and NCPAP group it is 7 with a median difference of 1.0 with a significant p-value less than 0.001. Sensitivity analysis was done for adjusting in the imbalance in the CRIP2 score, PaO2, study sites, and antenatal corticosteroids. In unadjusted base model, the risk difference was -12 with a significant p-value. And when CRIP2 score was adjusted, then the risk difference was -14.9. And when it was adjusted for PaO2, the risk difference was -9.7. And when adjusted for antenatal corticosteroid, the risk difference was -11.5. And when it is adjusted for the study sites, the risk difference is -12.1. All the parameters were individually adjusted. The strengths of the study were is a massive study with extremely preterm infants. Previous studies which were performed included most of the infants who were more than 28 weeks. And physiology targeted protocols were used with governing fluid, surfactant, antibiotics. Well trained and expert execution with level 3 NICU, independent and blinded outcome assessors were blinded. And limitations of the study were clinicians were unblinded, masking of the caregivers using distinct NHFOV devices is physically impossible, and narrow comparison, specifically only continuous flow CPAP machines were used, no bubble variable flow CPAP machines or no bubble CPAP arm was included. Extremely fragile infants who are less than 22 weeks represented a smaller fraction, which is 12% of the total cohort, limiting ultra low gestational age applicability. Evidence in two studies, which is one performed by Malkin in 2016 and other by Iranpour in 2017. Trend showed by Malkin et al. The number of neonates were 124 with a gestational age of 28 to 34 weeks. It is a primary study with infants with RDS were randomized to NHFOV versus NCPAP group, which showed lower failure rate in NHFOV 6.5% versus 14.5%, and significantly shorter duration of support, which is in the NHFOV group. But the lower failure rate in NHFOV was only significant. In Iranpur et al., with a number of neonates is 68 with a gestational age of 30 to 36. Infants with RDS were randomized to NHFOV versus NCPAP group. NHFOV significantly reduced duration of non-invasive support, that is 20 hours versus 26.5 hours. And third study was published in our institute by Rachana et al. With the infants of less than 34 weeks with the number of neonates 40. 20 neonates were randomized, but this is a secondary study. After CPAP failure, the infants were randomized to NHFOV and NIMV. Here NHFOV was better as say rescue against NIMV with 40 versus 45% failure rate. But however, the result did not reach a significant value. And recently published by Likita et al., which was performed in Ankura Hospital with just more than 30 weeks of gestational age babies, which is primary non-inferiority study. Here, inferiority margin was taken as 20%. They found that the risk difference between the both groups was 0%, and NHFOV was considered non-inferior to NCPAP for primary support in older preemies. Critical appraisal. Is the research question clearly focused? Yes. Was the randomization correctly done? Yes. Centrally managed computer sequences were used. Are all accounted? Yes, it is an intention to treat analysis. Methodology, were the groups similar? Yes, groups were similar except for CRIP2 and PaO2 deviation. Equal care was given according to the unit protocols in both the groups. Blinding, it was not possible for blinding of the primary care physician, but outcome assessors were blinded. Results, effects reported comprehensively, yes. Precision of estimate, yes. 95% confident intervals were reported. Benefits outweigh harms. Clear reduction in intubation rate with HFOV was seen, yes. And local applicability, nasal CPAP versus bubble CPAP. As in our settings, we mostly use bubble CPAP support, so we can't generalize these reports to our study. And high pressures in bubble CPAP. In bubble CPAP, in nasal CPAP groups, there are no oscillations seen, but in a bubble CPAP, bubble oscillations are still present. So we can't generalize these two, nasal CPAP and bubble CPAP. Different devices for nasal HFOV are used, and nasal interface. We mostly use mask, but in the study only binasal prongs were used. Here is the visual abstract of the study.
So thank you, Sharanya, for a wonderful presentation. And I will leave the stage open for questions and comments from both the experts, Pratima and Mangalabharati. So I think there are some questions from the chat box. Somebody wanted
Sir, shall we maybe just can we start with your views on the clinical impact of the study? I will touch upon the little statistical points. I think then we'll take up the questions. Shall we do it this way?
Yeah. So I thought this is a very good study, and a very large number of extreme preterm babies were enrolled. It's a very difficult to do study, and definitely a needed study. When we started the same type of intervention, initially when we did this study, we 28 to 34 weeks babies, our failure rate was 30%, and we could come down to 15% by using surfactant very early. So I was just thinking it's just a replica of that, but here instead of CPAP, we are trying to use nasal HFOV. So in extreme preterm babies where the failure rates are high, which are usually more than 30-40%, almost 15-20% reduction in the need for ventilation is a huge achievement with nasal HFOV. But logistic problems are many because nasal HFOV require a good ventilator and a costly ventilator. You will definitely need to have regular blood gases and more nursing care and more humidification problems. I don't know what humidification they've used in this study, but definitely there could be a lot of humidification issues when you are using nasal HFOV when the flow rates are very high. So that is why one of their main outcome was thick secretions. However, they found less thick secretions means their humidification must be excellent. The other issue is the interface. Maintaining an interface in a small baby and whether it's Hudson prong or whether it is any other, especially RAMS is a little difficult to maintain in extremely low birth weight babies, and the sizes and the interface itself are not very good for extreme preterm babies. We found mask as a very good interface, but this trial shows it could be HFOV and nasal CPAP will very well be done with binasal prongs. Exact details of the prongs are not available, but I assume that whether they use Hudson prongs or any other prongs, we are not very sure. Regarding the outcome chosen, I think most of us look as a ventilation as a very important surrogate outcome, but obviously it is not the hard outcome. Although they shows that some trend in decreased BPD, but for a study like this nature, we will look at BPD as a strong outcome. So coming to the other few concerns about the study, one is where in the initial phase they said they have an average of about 1,000 babies with eligible babies with RDS, and during this 2-year study we expect around 2,000 babies to be there, but they ended up only 650 babies who were eligible for the study. So what happened to the other, we are not very sure whether there was some selective selection of the babies happening or not, whether all consecutive babies born and admitted were given equal chance for randomization or not. We're not very sure because that would affect the external validity. But however, they've chosen babies who have required CPAP for long, at least half an hour, and requiring CPAP of 6 and FiO to 30%. Overall, I would rate it as a very important study, especially for Indian circumstances where we want to work on reducing the failure rates. But I would see how we can do the similar type of intervention in small babies with nasal mask rather than nasal prongs. So that is my take on the study. There are, as she rightly pointed out, there are 3 other studies. The first one was almost same, but a bigger babies and smaller number of small number of sample size. The other one also, Iranpur one also, is a smaller study and bigger babies. Veera has published just a study in just I think a few days back where he has used as a primary mode as a non-inferiority trial, and there again he has shown that in nasal HFOV is non-inferior to CPAP, at least even in our circumstances. So that is my take, and definitely a wonderful job, and doing such a large study in a large country which involved 20 NICUs is a huge effort and a very well conducted study.
So primary support means they have started the nasal HFOV in the delivery room itself, sir, or
Yeah.
they have started in the.
So they started with CPAP in the delivery room, and if they require CPAP for at least 30 minutes, the babies need to be requiring CPAP for 30 minutes before they are randomized. So, and the randomization happened within the first 2 hours after birth. So these babies are babies who require CPAP anyway. But if they required ventilation, they were not eligible for this.
Mangla, sir, you can share the statistical points, sir.
Yeah. Good evening, everyone. So thanks to NNF for the opportunity, and my salutes and pronouns to my mentor Saurabh sir, and again thanks to Murki sir and Dr. Pratima. I'll just take say around 15 minutes. The job given to me is to discuss some statistical points that we can learn from this study. I'll just have a very short presentation. Are you able to see my slides?
Yes, Mangla.
Thank you. So, Srinivas sir actually pointed out, just see that. I
Mangla,
believe,
we are able to see the.
sorry?
Need to share. You
It's
need
not
to
in
share
full
the
screen.
screen. We are able.
It's not in
Presenter
full-
view we are having.
No, 1 second.
It is presenter view. Presenter view.
Oh, 1 second. 1 second.
Yeah.
Is it okay now? Yeah.
Yes. Now
Okay.
it is good. Yes.
Thank you. So this study definitely, I believe, have a lot of statistical learning points. But I would like to focus on some 4 or 5 points. And we had seen some very important questions that had come up about the methodology also. We will try to discuss that once this presentation is over. So why this is a very, very important study? So we all know that this paper has addressed a very, very important question. And it's a very relevant and pertinent question to us neonatologists in our day-to-day neonatal practice. And if you look into the study design, it's a randomized controlled trial. It's a multicentric trial focusing on a very, very crucial population, ELBW neonates, a 20-center trial with a very good numbers. And they have given a significant result saying that HFOV is definitely superior than nasal CPAP. So having said that, are there any concerns or limitations? The purpose of Journal Club is to, when we are trying to learn from the strengths of these various studies, it's also that we need to be aware of the limitations of each and every trial, however good it may be. Let's try to focus a little bit there. So regarding the choice of outcomes, this is a generic slide, some 2 slides for especially people who are beginners here, who would like to know in such large randomized controlled trials, what kind of outcomes we should be choosing and why. In this trial also that we had come across these 3 terminologies, right? The primary outcome, secondary outcomes, and safety outcomes. For any trial, a clinical trial, we should first choose one primary outcome preferably. That doesn't mean that you can't take more than one primary outcome. Usually we take most of the cases because we do the sample size calculation based upon this outcome. So we choose an outcome which is the single most important crucial outcome, which is a direct answer to a research question, whatever is your research question. So that outcome should be the primary outcome, and we should have done a sample size calculation to show that our sample size, what we are going to do, the study is powered enough to answer the research question. All other outcomes where, even though we may be measuring them, so because when we are doing such a large trials, we're putting in so much amount of time, we collect a lot of data. So we usually prefer to show a lot of other data also, how they were between these 2 groups. But we need to understand, we have not done any statistical calculation on those. And usually we don't have the power to analyze these outcomes, and we are not decided a priori, that means before starting the trial, that we are going to analyze these with these numbers. So most of the time they're exploratory. They can actually give us some idea, or they can serve as a basis for further trials, larger trials, if somebody is interested in taking some of these primary outcomes as their main outcome. But that caution has to be there. And the third component is very, very important. Most of the time we are focused on efficacy, right? So whether something works, like whether if you use high frequency oscillatory ventilation, does it help in decreasing lung injury? So it may be measured in terms of BPD or things like that. But there is always a possibility this benefit may come at the expense or without us looking into realizing that some harmful effect is coming in. It may be known or it may be an unknown. So it's very, very crucial for clinical trials to have safety outcomes, to look for plausible harm. And so we need to interpret these 2 very carefully. We need to show that there is a benefit, but it is not compromising the safety. So what about this trial here? Sorry, go back. Yeah. So what are the choice of the primary outcome here? So they had taken intubation within 72 hours. So what is good about it? So this choice of the primary outcome for this study is very, very clinically relevant. Whenever we talk about non-invasive, most of the studies, what we see in literature, even meta-analysis, they have just taken this outcome, right? Intubation within 72 hours. We try to minimize or prevent intubation, which is a harmful thing. That's how we believe, and it is easy to understand. And it is it's common enough to achieve statistical power, and it is well suited for a superiority trial like this. But what is the downside? We all know that just because somebody got intubated doesn't mean that they are going to develop, whether there is going to be a difference in very crucial outcomes like survival or outcomes like BPD, IVH, ROP, whatever it is. So that is what we mean by a hard outcome. So this is where we need to be very clear. As far as possible, when you are choosing studies, we should prefer to choose hard outcomes like death, conditions like severe IVH, NEC, BPD. These are examples for this research question. Obviously, it might differ based on your research idea or question. Choosing outcomes like intubation or some form of escalation of support, I'm not saying that they are meaningless. They are reasonably easy to do. Many times they may be the pragmatic or practical ones, but definitely they are considered inferior compared to the hard outcomes. When we don't find differences in the hard outcome and we see the benefits only in soft outcomes, we have to be very careful, and then we can't conclude with confidence that this minimizes lung injury. That's what is happening in this trial as well. So again, just here, even though in this study a positive primary result is shown, in my opinion, I'm not very sure that whether this can guarantee clinical benefit, because there is no difference in deaths, there is no difference in BPD, there is no difference in this trial on major significant morbidities. Of course, we don't have any idea about any long-term neurodevelopmental outcomes. So that always we need to look into whenever we are interpreting larger trials. And even if we are measuring secondary outcomes, or what we call as in exploratory outcomes, so please at least remember that you don't bring in n number of secondary outcomes. Just at least limit it to a handful of or very important ones. So more the number of secondary outcomes, many things can just turn out to be significant just by a pure chance. So, and then these are just exploratory. So please avoid planning trials with very huge number of secondary outcomes. So moving to the second point, actually, this is very, again, interesting if you have noted. So one is the choice of the primary outcome. The second one is that how do we measure that, once we measure it, how do we measure the strength of association? How the effect size? So most of this clinical trials, we know the results are in percentages. Here it is the intubation rate. There is an X% in high frequency group and an Y% in the CPAP group. Usually you would have seen them being compared as relative risks, or what we call as a risk ratio. But here they have chosen a risk difference, which is an absolute difference. So it's worth understanding the difference between these two terminologies. Both are just trying to find out how different they are. One is a relative way of looking at things, how relatively one group is performing well or bad compared to the other group. And the second one is in terms of absolute difference in terms of numbers between the two groups. So the choice here, I'm not saying this is bad, this is really good. For a clinician, the first question that they may ask is that, okay, if HFOV is going to decrease the number of intubations, so what is that number, exact number? How many intubations are less? So here they have shown that number to be 12% around, decrease in absolute number. So we know that this can be easily translated into what we call as the number needed to treat. It was 8 here. While it has a lot of positives, we need to understand the little bit downsides of using a risk difference without a risk ratio. So what is that? See, the absolute differences depend a lot on the baseline incidence. If our baseline intubation failures are not the same in your setting, like what these people have shown, I have no idea. For example, let's say in IOG, in my setting, in extreme preterm babies, even on CPAP, my failure rates right now are sitting at 60%, let's assume. So if I'm following this paper, if I'm applying this, will it be a 12% absolute reduction from 60? Or if they had provided me a relative numbers, I will know by proportion from 60. If there is a 50% difference, it may be 60 might become 30. So that kind, so all that I'm trying to say, it may be worth providing both, because both have their strengths. So it's good to report both risk ratios and risk differences in these papers. The blinding, we all know that this was obviously in such trials, it's very, very difficult. So that downgrades. Rather than the blinding, which is difficult to do in such trials, I'm worried about one bias here. One of the reasons or the options given for intubation is an urgent intubation decided by a clinician. That is the fourth option. There are three options which are very clear. Whenever there is acidosis, worsening hypoxia, and apneas, people intubated. But fourth option was when a clinician felt urgently it needs to be intubated without explaining why. So that gives a lot of, even though that numbers were less in a trial, large trial like this, that could have brought in bias, and we need to be very careful. And people have asked this question in the question box also. I also felt that the terminologies, what they have used here, they have used only one terminology commonly, like sensitivity analysis. For the various kinds of analysis, what they have done, I'm not sure whether they are wrong, but it is a little misleading. That's what I believe. So I will try to explain what we mean by these two terms. What is an adjusted analysis and what is a sensitivity analysis? In general, just because we do randomization, even though the main purpose of randomization is to make sure all the variables get equally distributed across the two groups, often we end up in some disparity or dissimilarity between the two groups. So what does that mean? Again, this question was asked in the question box I saw, so I can answer this here also. Whether we need to calculate p-values for all baseline parameters to make sure that whether the baseline variables are equally distributed between the two groups. No, absolutely no. See, we should be, that actually definitely it breaks the main purpose of randomization also, especially. So we focus only on certain predetermined, if possible, some variables, very important prognostic or clinically significant parameters, which may have to be adjusted later. So just because don't give p-values for all the variables, just don't adjust for anything and everything. Do away from this is not all recommended. But having said that, if some important prognostic variable is unequally distributed, then it is worth adjusting for that variable. And it is better to you decide those in advance and write it in your protocol. Just say, I'm going to do these analysis if these parameters are going to be different. That's the best way if it is pre-specified here. And so adjusted analysis in general means when baseline parameters are not comparable, we try to do an adjusted analysis. Again, here they have used the term in this study, the Scripps score and the PaO2 levels were not equal between the two groups in the baseline. But usually we prefer a single kind of like a logistic regression, multivariate regression model, where we put in all these parameters and see what is the effect, ultimately how it changes. They're not done here. I don't know why. They've done only for individual parameters separately, and they're calling it as a sensitivity analysis. In general, sensitivity analysis is applied with something like what if this was different? What if there could be a lot of missing values? There could be a lot of protocol violations. If the babies were in the other group, or if the drug was not given properly, if it was given properly, if the missing data turned out to be something in one side, for that kind of things, if we do that, still if the results holds true for what we call as the robustness of the results, that's where sensitivity analysis in general used. And don't get confused again with the subgroup analysis. This is about the same analysis in different groups. We divide the population into various subgroups and then this has nothing to do with the sensitivity analysis. So I think I'll leave this part. I'll not confuse you with the slide. If there are some questions, I'll take it up later. This is also very interesting. Actually, this I'm bringing in only for, I know it's a very tricky issue to handle twins in a randomized controlled trial because they can never be considered as two independent patients because they share a lot of maternal and delivery characteristics. So it's very, very difficult to make a decision. How do we randomize twins? Like as two different individuals. In this study, I read the protocol. They have said that they will actually they will be randomizing both the twins into one group. That's what is written in the protocol. But I don't find anything in the main paper. If they had followed that, then it is worth doing some advanced analysis to see whether the impact of twins, which they have randomized to one group, both the twins, whether it doesn't negate the results what they are showing because they have become clustered. They could have looked into it. So I'll stop here, emphasizing more on just please be careful whether we are talking about hard primary outcomes and not soft clinician. And we should be very careful about interpreting clinician triggered outcomes like the urgent intubation here. It's very good to report both the risk difference and the risk ratios and keep your secondary outcomes to minimum. And then, of course, we discuss something about the various kinds of analysis. What do we mean by adjusted analysis, sensitivity analysis, and subgroup analysis? I'll stop here and maybe again pitch in if I have to answer some questions. Thank you. Over to you, Pratima.
Yes, sir, we can take questions, I think, sir. Mangla, sir, shall we start taking, sir?
Yes, please. Yes, please.
When
Mangla,
you think-
before you go, I
Yes,
think
yes.
there was one small error. I don't know whether you call it error or not. In the baseline variable, the duration of the primary treatment is 24 and 25 days. Will it come as baseline or will it come as outcome? I'm not very sure. Maybe you should.
Sorry, sir. I didn't get your the
In the
second.
baseline variable, they said the
Ah.
duration of the primary therapy was about 24 and 25 days. In the
The
baseline.
duration of treatment.
So these duration is happening after the primary and some of the secondary outcomes, isn't it? So will it come in the baseline or will it come in the outcome?
Yes, sir. I fully agree. But I think maybe Saurav sir can answer clearly. Whatever happens after the intervention, obviously cannot be considered as a baseline variable. They should be called as an outcome only. But many a times we do see co-interventions and some of the outcomes getting reported in the baseline table. I don't know whether it's because of the number of table restrictions in these large papers, people try to put it under baseline. Sir, Saurabh sir, you please help us, sir, in understanding.
Yeah, no, I agree with you. Any event that happens after the intervention is an outcome from a purist's point of view. Or it is a co-intervention, but some would say even that co-intervention is an outcome. I mean, you provided that co-intervention, especially in unblinded trials. If you know what was the intervention, then you may have a tendency to provide a certain co-intervention simply because you knew what the intervention was, which, again, strictly speaking, makes it an outcome rather than a co-intervention. But anything which is after the intervention cannot be a baseline characteristic in a nutshell. Yeah, please go ahead.
Pratima, do you want me to take up the questions? And
Yes, sir. Yes,
yeah.
sir.
So I'll just go one by one and then order starting from the beginning. See, somebody has asked what is the difference between masking and blinding. So they are the same. I think that just to be not to get confused with the visual blinding, the term which is loosely used, I think it is preferred to use the term masking. So they are both the same. They are not different, masking and blinding. No need for any confusion.
Mangla, while you are there, I've had some problem in understanding the masking here. They said the data was retrieved by independent assessors. So, and they mask the treatment assignment. Okay, you can mask the treatment assignment, but lot of data is visible. If you see the delta P and if you see the frequency and if you see the blood gases, you will easily know that these data is coming from a particular group of patients, isn't it?
Yes, sir, yes. But I think what they have given, I don't know how rigorously they implemented it, but what they had written, they had appointed independent assessors for each center for measuring these. They were not part of the clinical team. So clinical team would have recorded all these things. But the data retrieval, they said, was done by an independent person who was appointed separately for this purpose per center. who didn't know in which group they were. But whether that retrieval came on a daily basis from the, maybe if they had just provided blinded case sheets to them, to this assessor, and so from that case sheet it was retrieved, then we can say at least the assessment part was masked.
No, if you look at the protocol, they had every day they had to do it. They had a timeline at which each thing has to be reported online. So if somebody is looking at the case sheet so many times, I'm not very sure how much time you can avoid because this is visible data, isn't it? So it's the people who are assessing, how will they skip not looking at the ventilatory parameters?
True, sir. I agree. I agree.
I mean, just to be critic, I was, I was thinking, how could one do that? Aurav sir, how is it possible, sir?
No, for all practical purposes, this was an open label study. You know, whatever words they may use to mask the fact that it was not masked. It was, yeah.
So, shall we move on, sir? Were the treatment failure criteria uniform across the recruiting centers? Yeah, definitely. They had taken measures to make and they had explicit treatment failure criteria, except this part, like an urgent intubation, which is a subjective part. The other three were very clear. They had given clear-cut recommendations, the same across all centers. Somebody had asked.
Even there, Mangla, I had some problem because many times babies are intubated not just because of hypoxia or apnea. They're also intubated because of increased work of breathing, and sometimes because of shock or other parameters which are not there in this trial. How could a extreme preterm baby have only these 4 criteria for intubation?
Yes, sir. I think that's a very valid question. But one thing I observed is that they have a very low threshold for intubation as well. Whenever the FiO2 exceeded 40%, they recruited at 25, and at 40, if it crossed, they intubated actually.
But
So,
that again is
yeah.
40%. I was surprised that they had only 30 failure rates.
Seeing whether they can argue whether this 40% is good enough. And there is a component of acidosis also. They have a FiO2 more than 40 and pH less than 7.2. Provided they were doing frequent blood gases, maybe these two are reasonably good enough to pick up sick babies, which might have required intubation. So there is a question on safety outcomes are usually not powered. So how do we decide the continuation of the trial based on safety outcomes during interim analysis? Again, I can say only the theory. I'll pass on the question to Saurabh sir. All that I know is that in general, when we say safety outcomes, they're relatively rare outcomes compared to efficacy outcomes. So if we are going to power for safety outcomes, I think it's not going to be possible to conduct any trial. The number is going to be huge unless safety is your primary research question. If your primary question is about efficacy, and if you are measuring, but also you want to measure safety, so usually in larger trials, definitely there would have been a data safety monitoring board, and there are predefined rules written by which the DSMB uses to make a decision whether to continue the trial or stop the trial. But I don't think they look into the power component. Sir, over to you, sir. It's a difficult question for me.
No, it's true that almost all superiority trials are underpowered for safety. As you said, the adverse events are so rare compared to the efficacy events that almost all trials are underpowered for safety. And especially with drug trials, safety issues crop up only during phase 4 trials. That means post-marketing surveillance is what brings up most safety issues to the fore. And so that's unfortunate because these get picked up only after the drug has already been used in a lot of people. So that is a problem.
I think there was a question about sensitivity analysis. I think I have discussed it already in my presentation. And interfaces, I think definitely that comment was made already by Murki sir also, like they had used only binasal prongs and they have not used masks. the same way that they are not used bubble CPAP systems. They have used only continuous flow CPAP systems. But I think that it's a difficult balance to look into. On the other side, I saw a comment saying that they had used different kinds of ventilators for providing high frequency. So on one hand, when we want to restrict to only one kind, like say use only one type of interface, use only one type of CPAP machine, maybe the trial is more uniform, it is more rigorous by design. But obviously, we start asking questions about the generalizability, right? Okay, if I'm using a different interface, if I'm going to use different kind of machine, the result might be different. That issue is there. It's always a balance between. So most of the time, it's good, I think, to be realistic. We need not have restricted only to one kind of a machine and all. Maybe as a concept, I understand bubble CPAP versus flow CPAP or continuous flow CPAP may have differences. We may have reasons to believe whether this will work differently in a bubble CPAP. But as far as the machines of high frequency, I don't know whether we should restrict to. I personally believe that it's better to, as long as those are validated machines and standard machines used in neonatal care, for the generalizability purpose, it's better to have more machines.
Magala, on that note,
sir.
can I just
Yes,
jump
sir,
in?
please, sir.
Yeah, so one of my professors had told me that, if one is going to be a purist, that means if my machine is different than that person's machine, so therefore I may not be able, then you'll never be able to do any clinical practice. So the question you have to ask is my machine so different from that person's machine that I cannot use the findings from that study? Rather than, be negative and say that my machine is different, so therefore I cannot use. The question should actually be, is my setting so different from the setting of the paper, or is my machine so different from this thing that I cannot use the findings from that study? So if my answer is, okay, it's not so different that I cannot use, you should use the findings from that study. You can't possibly be doing different studies for each machine. That's simply not practical and not even justified. Okay.
Thank
Please
you,
go
sir.
ahead.
On that line, the external validity is going to be very good for this study, no, sir?
Yes, I mean, we should not be trying to find ways to make it non-generalizable, but should try as far as possible to see what are the commonalities so that it can be generalized, rather than, picking holes and saying this is not generalizable to my setting. It should be the other way around, a positive attitude.
So somebody had asked about the design of the trial. It is very clear. It is a superiority framework. They started with the hypothesis that high frequency oscillator ventilation will be more effective than CPAP. Somebody had asked about CPAP settings and pressure settings. There are some 2 or 3 questions. That's again very interesting about this study. I think we know that the argument about the NIV versus CPAP comparisons also. So whenever we find difference between these different types of non-invasive support, if you find a difference, is it just because of the kind of support what we are doing, or is it just because of the difference in pressures? Obviously, NIV, if you calculate the mean airway pressures, it will be much more compared to the CPAP. And we have always listened to arguments saying that if people are using higher pressures in CPAP, maybe they will get the same benefit rather than NAV. The difference may be because of the pressure. So here I find actually they have tried to address this issue. They said that even in the high frequency group, I will be using a pressure of around 6, which they had a small leeway. Obviously, it is not possible to keep the same number. They always had a plus or minus 1 or 2 readings. But they had an intentions, and they had some, a common agreed protocol to maintain similar levels of pressure in the high frequency group and the CPAP group. Of course, there is an added component of oscillations and other things, but that was the baseline they have shown. But at 24 hours still in the table, the pressure difference seems to be there. High frequency has used higher pressures compared to that of CPAP. I'm not trying to say absolutely same pressures were there, but the investigators have tried their best to equalize reasonably the pressures in the 2 groups. impact of delivery room CPAP on this outcome could have started at delivery point. Yeah, again, as Saurabh sir was repeatedly saying, from a purist point of view, you might argue this intervention should have been started in the delivery room. But this is a very practical, pragmatic way. We know that however small they may be, there are certain babies who are going to settle down soon, who may not have recade support. So having delivery room CPAP for a short time, for 30 minutes, as the first setting, and then so this is a more real world setting. It's more pragmatic. That may be more meaningful. I don't think that's a limitation in this study. Somebody has asked why FiO2 initial 25 was taken as NRP recommends more than 30. This is not about resuscitation at all. This is about the need for support, respiratory support. Nothing to do with resuscitation in this trial. Subgroup analysis, they have not done a subgroup, but they have shown they have themselves have mentioned in one of their limitations, they had very few babies less than 26 weeks. Predominantly, it was a 26 to 28 weeks group. But as ELBW, they are taken as one group. They are not done any stratification. There was a question about stratification also. No stratification was done in this trial. It is not a stratification was done only for the center. There are 20 centers. So it's a stratified randomization per center, but not for any particular gestation groups. Pratima, have I missed any question? I think I have gone through the
So
questions.
you have covered, I think, risk difference and relative risk you already covered during your learning point.
Somebody asked about the hard outcome varies for each study and a research question, or is it fixed like death, ROP, and BPD? Obviously, see, when we say hard outcome, something which is non-debatable, which will just definitely, which everyone will agree that if there is a change in that thing, then definitely this is going to be beneficial, where there cannot be any bias, or it can't be an interim factor, which is going to lead to something else. That itself has been an important endpoint. We can say clinical endpoints, relevant and important clinical endpoints are called hard outcomes. That you choose whatever is relevant to your research question.
Regarding hard outcomes, there has been a recent attempt at defining core neonatal outcomes that should be reported in all randomized controlled trials as far as possible if they're relevant to your research question. So there is being some effort. I think in JAMA Pediatrics carried a series of articles on the core outcomes in neonatology, and one must make an attempt to include those core outcomes as one's primary outcomes as far as possible, to the extent possible.
Saurabh sir, just actually, I had one query which I tried to find answers to when reading this paper, because as per the hypothesis, the proposed effect size was 15%, absolute difference when they calculated between these two groups. And that's the number that they tried to reach. Of course, there were some dropouts, but that was before randomization, not post randomization. So they were not able to even achieve their proposed, some 15 or 20 numbers they were short than what they had calculated. But they ultimately picked up only a 12% absolute difference, but it was statistically significant. So whenever we are just looking at picking up effect sizes which are less than what we intended earlier, so is it again happen? There is a lot of chance element to, we should be lucky, sir, or how do we call this when we are picking up even smaller differences?
No, I think, see, even sample size calculation is an approximation. You're making a few assumptions, a few guesses, and so on and so forth. So it may happen that your risk difference was less, but then simultaneously your baseline rate was also less. So compared to that low baseline rate, now this lower risk difference was still quite big.
Yes.
Which is why you still picked up a statistically significant difference. So that can happen at times.
Yeah.
So then you have to ask yourself that, is my 12% so much less than my 15% that it makes such a difference, picking up such a difference worthless? I think most of us clinicians will say, well, even a 12% difference in, is something worthwhile. So yeah, there is always a little bit of a judgment element, a judgment call, and so it can happen that. And we have to remember that the sample size calculation itself, there's nothing sacred about it.
Yeah.
It is itself based on so many assumptions.
Thank you, sir. I think we have covered all the questions. Saurabh, sir, any final one more comment? The p-value is 0.008, not less than 0.005, but still taken significant.
Oh, 0.008 is less than 0.005.
No,
Okay,
0.05 is given,
0.05.
not
0.05.
0.005. Yeah.
0.05, yeah. 0.05, yeah.
0.05. Okay, Saurabh, sir, any comments or any learning points?
No, thank you. I think all the speakers have spoken marvelously, and even the questions were very, very pertinent. And I think Dr. Mangalavarthi and Dr. Srinivas both did a great job. So did the presenter. Yeah, you can probably wind up.
Yeah, thank you, Sharanya. Thank you, Mukesh sir. Thank you, Mangla sir, Saurabh sir. Thank you all for joining. The next journal club will be on 24th April, the last Friday of next month. Good night, everybody. Thank you, sir.
Thank you, everyone.
Thank you. Thanks, everyone. Good night.
Thank you.